Well, it's my pleasure to go ahead and introduce this webinar and talk to you about hallux rigidus and some of the just difficult things that we're dealing with, that we're challenged with. I've been
What's going on?
interested in this. Uh, is my sound coming through okay? Okay. I've been interested in this topic for a number of years. These are my conflicts of interest, and this is my CV, but I'm not going to waste time on this. I really want to get to our topic at hand, which is what I became interested in early on was just typifying the different grades of hallux rigidus so that we could all chat together and have uh, a way to communicate. So, but in simplifying this, grade 1 is a little bit, and grade 2 is a little more severe. That I still think a chilectomy works there. Grade 3 is getting more extensive disease. And my study really hinged on where could you do a chilectomy, and when you have more severe disease, where did you have to basically bag it and move on to something else? This was a 19-year follow-up study with one of the larger groups of people with hallux rigidus. We did chilectomies and arthrodeses on a single surgeon's experience, and we have continued to follow them for a number of years. So chilectomy was sort of the gold standard. It had been well studied. It was simple. It was effective in both the podiatric and the orthopedic communities. And if it didn't work, it was salvageable. What I really came to understand in my study was that arthrodesis really was the real gold standard for a grade 4 hallux rigidus. And it was all about motion and the joint space remaining. And if people had pain at that central area, then a chilectomy really wasn't very fruitful. Then we went on to MTP arthrodesis and really worked to try to fine tune this treatment with things like reamers and dorsal plate fixation. And these people did actually very, very well with an arthrodesis and with other concomitant procedures. We looked at the AOFAS score for arthrodeses. Their preoperative score was fairly low, and the postoperative score was fairly high, and the subjective score was good. But what really continues to drive the bus here, and why we're talking tonight, is not everyone wants a stiff joint. Now, there have been all kinds of efforts in the past. I know Carrie and I both were very involved in these kinds of things, from silastic implants to cemented implants to even 2- and 3-part joints. And they all were pretty expensive, and they had a very high failure rate. And so that wasn't a way that really was very successful, but was certainly a lot of time was spent on this. I then went down the road of an interposition arthroplasty in the quest to retain mobility of the joint. This is I would say, a grade 4 joint. We reamed it, and then after we did that, we prepped it, and we used this as Arthroflex. It's a dermal implant from Arthrex. There are a lot of graft jacket and other things that are out there. We made basically a condom over the head of the metatarsal head, but it's a lot of surgery. There's no question about it. And for a grade 3.5 or 4 hallux rigidus, that was probably the thing that we found that worked better, certainly than any of the joint implants, and certainly better than chilectomy, but it was a lot of surgery, and there were complications with this as well. So I consider this to be an unsolved problem that we continue to struggle with. And you can see all the different alleys that people have gone down trying to find a better solution. And one of the things that they did, obviously, was Cartiva. In Cartiva, you see the hydrogel implant sort of separated the joint in order to distract, say, a 3.5 hallux rigidus and try to maintain motion. I was asked to be part of this study, and I know that it's a level 1 study, but just because it's a level 1 study doesn't mean it's wonderful. And the thing I didn't like about it is they were fusing grade 2, 3s, and 4s, and it was a blind randomized controlled trial. So I might have somebody that I would hardly see. This person with a grade 2 might not come in. The 3s and 4s would come in, but a grade 2, if they came in, might be in the mix to get fused. And I can tell you, the one person who doesn't like an arthrodesis is one that is done very early on, like, say, a grade 2. So this made Cartiva look much better than it probably was. So I want to show you, this is just a 50-year-old female that presented to our clinic with severe bilateral hallux rigidus that really limited her lifestyle as a photographer. She previously had an MTP chilectomy about 5 years before. There are preoperative radiographs that you see here, and we ended up doing implants, Cartiva implants on both sides, and bilaterally. Here she is at 2 months post-op. Here she is at 7 months post-op, complaining of worsening pain at her first MTP joint. She originally was doing quite well, but at 4 to 5 months, she just kind of went into the gutter with this. This is her 7-month post-operative radiographs and was explored and ended up with bilateral arthrodesis. Now, I'm not taking Bob Berberian's thunder because he's going to talk about this as well, but I just wanted to bring this up because I was early on in this and I was frustrated with the treatment. I didn't want to be part of the study, and I'm pretty much sad about the residual that we see here as well. Other alternatives, well, when we're looking at metatarsal articular surface intraoperatively, this was one of our take-home lessons, that the remaining cartilage at the time of surgery, less than 50% correlates with failure. And so that's why we would then move on from a chilectomy to an arthrodesis. And of course, then when you have someone with severe hallux rigidus, and you see an MRI with a lot of disease there, these patients many times want you to preserve their motion. And that's the challenge that we have, is trying to provide that for them. So I show you one other provocative case that I think is really interesting. Is a combined hallux valgus and hallux rigidus problem. Bunion pain, but it's deep in the joint. Pain with dorsiflexion and plantar flexion, and you're convinced they have a combination of both hallux valgus and hallux rigidus. And this is a picture that sees that strip of lost articular surface right in the depths of the joint. So what we tend to do at this point is what we've done in the past is an arthrodesis, but again, salvaging the joint with an arthrodesis may not be what they really want. This is another case, but it's similar with a lot of plantar erosion. It's just more extensive disease. And so here's the bottom line here. And the reason I'm really interested in the subchondral solution is the factors we look at are age, activity, and level of degeneration. Maybe it's an arthrodesis, maybe it's a soft tissue interposition, but we'll see later from some of our players here in our discussion, maybe a subchondral implant. This is an orphan joint, and we need to continue to strive to retain motion and do a better job here if we can. With that in mind, I'll stop sharing my screen, and it's my pleasure to then pass the torch to Bob Berberian, who's going to go ahead and talk to us a little bit more about, I know, some Cartiva cases and so forth. Bob?
Hi, guys. Let me just get myself set here. Sorry. Everyone see my screen okay?
Yes.
Okay. So basically, I got involved with the Cartiva implants very early also. And the way it was sold to me was that this is kind of the holy grail. We're going to be able to do incredible things with it. And I've actually found hallux rigidus, hallux limitus to be one of the more difficult things to have satisfying results with. And the main reason was patients come in and they have a painful joint. They don't quite understand what they have. And as you work them up and try to figure out what to do for them, I found that when you do chilectomies, like Dr. Coughlin was saying, sometimes you open the joint up and you're surprised by the level of disease. And sometimes you open the joint up and you do a perfectly good chilectomy and you end up still having joint that's painful. And so when Cartiva came about, I was like, this is going to be amazing. It's going to help preserve the joint. It's simple to do. It's very easily repetitive by the surgeons. And we got involved in it very early on the education forefront too. And the beauty of it was that the implant was supposed to mimic cartilage. It was supposed to be a cartilage replacement system. And the ease of use was something that was wonderful because you really could teach it to almost anybody and they could learn it and repeat it fairly easily. The problem was that as we started to put them in, we found that there was significant subsidence right from the beginning, but we didn't understand why. And it took us about 6 months to understand that the subsidence was related to the implant. So when we put it in, we would do an aggressive chilectomy, put in the implant, try to center it, and it looked great. Your immediate x-rays looked fantastic. You had joint space, your range of motion was great. But what was happening was almost all of our implants within a very short amount of time were finding to be subsiding. And the interesting thing was that the patients would come in almost on their first visit and be like, you know what, it was good at the beginning with the first few days, but now I'm finding that I feel that same feeling. And at the beginning, we were like, well, it can't be, the implant's sitting there and it's doing its thing. But on radiographs, we would find that the joint space was somewhat narrowed compared to our intraoperative x-rays. And the other thing that we keep considering was that it was easy to place and it doesn't burn a bridge, which I'm still very happy about. But the question is, why were we getting the subsidence? And I have my own theory, and I think it's related to the fact that this implant would be hydrated. So before you put the implant in, you would hydrate it. And the implant would actually somewhat grow in size. And then you would take the implant and you would squeeze it, much like one of these dolls that you squeeze the head of. And after you squeezed it, that you would pop it into the hole and the top would mushroom out. But I think that because you have a dry joint and there isn't fluid in the joint, there's a chance that the implant shrinks in size and subsides. And once it subsides in the bone, then it can't liquidate itself again to hydrate and come back out. And one of the biggest things that I found was, I've now probably done more Cartiva revisions than Cartivas, that the emotional stress that the patients had after a failure was fairly significant. They were having significant problems with emotional stress. And so, what was the reason? I don't think anyone knows why this was happening. I think it's possibly due to shrinkage, possibly due to dry joint syndrome. And the other thing that was interesting that no one had spoken about was that this implant had been tried in the knee with significant subsidence issues. And so that could be that it was a failure to start out with, and they tried it in a different joint and it didn't work. We looked at our results with Palo Alto Medical Foundation, and we took 40 cases, 20 from us, 20 from them, randomly pulled radiographs, and we had 100% subsidence rate. And the most important thing is to realize it's not your fault. This implant was flawed from the beginning. And I think now the goal should be to figure out what's better. And I think that really what we're starting to realize is that the subchondral bone is much like rebar, or the foundation of the structure. And without that rebar and foundation, no matter what you put on top of it, it doesn't work. And so you need to deal with the underlying bone and anything hollow underneath the cartilage and subchondral surface before you can go further. And really, my current thinking is that it's not just a cartilage issue, it's a cartilage and bone issue. And so we need to treat the bone and cartilage and make your bone structure strong before you layer cartilage or some sort of a soft tissue material over the top of that. And you know, we've done drilling for years, and we thought the drilling is in order to release the subchondral, to lubricate, to vascularize the subchondral bone. But I think part of that drilling is actually increasing blood supply to the subchondral bone and taking away that subchondral damage. So I think that the subchondral solutions material can help to control the scaffolding underneath the cartilage and allow you to put a layer on top of it. And I think it's very different in its function than the Cartiva. And I want to make sure that people understand that this is not a Cartiva implant and nothing to do with Cartiva. And really to make sure that you understand that this is a bone and cartilage issue. This is just to give you an example of bone and cartilage. You can see that you sometimes get in a joint and there's a cartilage loss. And what I would do is take some cartilage, morselize it from the dorsal surface and put it into the hole. But now what I'm starting to do is actually use other implants to try to fill that subchondral hole and then cover it with a graft material, much like Dr. Coughlin was talking about. I hope that's helpful, and I'm going to stop broadcasting and pass it over to the other doctors.
Yes.
Dr. Zhang, I think you're up to bat here.
I'm having problems with my IT guy. It'll take us a second. All right. So I'm going to talk about the subchondral bone complex because I think, Bob, you hit it right on the head, and you weren't sure why, but I think you really found out why. So, we're talking about hallux rigidus and degenerative joint disease, and it's really a major cause of pain, disability. It's a progressive degenerative joint disorder, and it creates quality of life issues, and we all have to deal with that. So the characteristics of the cartilaginous damage is the pathologic structural changes in the subchondral bone complex that I think creates the problems. And with that, you have formation of osteophytes, muscle weakness, and inflammation of the synovial tissue, everything that really know about. And relative to the subchondral bone plate, the subchondral tuberculation of the bone is porous, metabolically active, and it contains all the blood vessels, sensory nerves, bone marrow. All of this is necessary for the normal and total joint health. And all of it is necessary in the healing process after injury or after our localized care. And this microfractures are non-traumatic in nature. They occur immediately below the articular cartilage, the tide mark. Early in the process, X-rays are unremarkable. An MRI evaluation oftentimes can reveal early and sometimes significant bone marrow edema and osseous collapse, even though we don't see it on X-ray. So the subchondral bone sclerosis, together with the progressive cartilaginous degeneration, these are the hallmarks of osteoarthritis, and we deal with this all the time. The bone is hypomineralized, and it's due to abnormal bone remodeling. There's histopathological changes in the subchondral bone complex, and including micro damage, fractures, bone marrow edema, bone cysts. So the pathologic process develops as an unstable, it's an unstable base for the surfaces, and we're doing surgery on an unstable base. And that's where we talk about the problems with cheilectomy. And I think the subsistence level and the problems with Carteva was you just put it into a mushing base, so it just moved around. And that this leads to the joint space narrowing, incongruity of the first metatarsal phalangeal joint, degeneration, thinning of the articular cartilage, and this has progressive biomechanical imbalances, and the progressive instability of the subchondral bone provides an unstable platform for your articular surface or for any implants that you put on. So, and there's been many different classifications over the years. The classification that Mike and Dr. Shernis put together probably close to 20 years ago has become the gold standard, but really in grades, in the first 3 grades, sometimes early on, there was no X-ray changes, some early osteophytes, and you didn't see on X-ray the changes until you got to grade 3 and grade 4. And this just shows the process. And when you get down to 3 and 4, you're looking at fusions, but we want to deal with that before. So this leads us to a lot of questions. Our legacy evaluation is both by clinical and X-ray. But was that really enough? So the X-rays showed minimal to no changes in the great toe joint in stages 0 and 1, minimal changes in 2, progressive changes as we went on. So are the subchondral changes of degeneration, are they occurring, but we're just not identified during our physical examination? I think that's probably what happens. That also leads to several other questions that we have. So what came first? Dysfunction of the articular cartilage or the subchondral insufficiency? Do we help to help ensure better surgical result? Should we be considering not only X-rays, but focused MRIs to our patients with multiple risk factors? And you said it earlier, Bob, have you ever wondered why your patients continue to have post-surgical pain and unexplained articular collapse or aseptic necrosis? And if you had unsatisfactory results when you knew that you did the surgical procedures flawlessly? And I think all of it goes back to subchondral insufficiency. That's our problem. So subchondral insufficiency can present without obvious clinical and objective manifestations. There's no disease-modifying drug therapy available to attenuate the process, even if we recognized it. And while pharmaceutical therapy was directed at either a specific joint or generalized degenerative arthritis or inflammation, or surgical efforts were directed towards a specific problem, we were just managing we were being reactive. We were managing the symptoms and not dealing with the process. So we need to control the postoperative progression of the degenerative changes that's occurring in the great toe joint. And the pain associated with this process has really been a challenge to foot and ankle surgeons. And I think that the subchondral bone complex plays a very crucial role in the initiation and the progress of the degenerative process. So the functional summary, the articular cartilage of the subchondral bone, all the components are functionally interdependent. Any alteration in the structure of any one component will alter the function of all of the other components. And all component functionality needs to be assessed and recognized. Otherwise, we're not able to formulate a more specific surgical plan. So the surgical problem is there's a dozen techniques out to address bunions. And colectomy is used most frequently in the early stages of hallux rigidus with the hope of preserving the motion and postponing further surgery. But the colectomy does not prevent the disease process, and we know it's not a permanent solution. And arthrodesis has been the gold standard for end-stage hallux rigidus, but in today's world, nobody wants an arthrodesis anymore. So in conclusion, we need to determine the extent and etiology of the degenerative changes of the great toe joint that are critical in formulating our surgical plan. And we need to do more in diagnosis hallux rigidus. I mean, many times we look at the x-rays and we think it's not so bad, and we go in and we open it up and you see actually areas of the articular cartilage denuded. Well, what came first? Subchondral microfractures or the articular cartilage? We're now seeing in our patients, and we're out next, and Dr. Ascari will show you that later, and so will Dr. Schulman, that pylectomy is still a very good procedure, but with appropriate adjunctive procedures, this allows our surgical procedure and intervention to be both reactive and proactive. It gives us the opportunity of not only attenuating pain, increasing functional capabilities, but we're hopeful that as time goes on, it'll negate the need for subsequent surgery. And, does Subchondral Solutions have a solution for subchondral dysfunction? I think the S-Core has that definite potential. The thing is that I think that we're finding in our group on grades 0, 1, and 2, we are getting MRs. And surprisingly, when we're seeing normal x-rays, we're getting MRI backs, and we're actually showing that there's not only bone marrow edema, but in many cases, there is subchondral insufficiency and microfractures that are present. And I'm going to talk to Mike about maybe we might revisit that and do another study and make some additions to the grading system that has the gold standard, so it remains the gold standard. So at this point, I'm going to bring Dr. Ascari on, and he's going to let you get a firsthand look at how this S-Core works. Thank you. Take it, Shah.
Thank you so much. Can you hear me?
Yes, we can hear you.
So it's definitely a pleasure being here today, talking to everyone. I wanted to take this perspective intraoperatively. Obviously, Dr. Zhang has talked about how we're trying to accomplish the subchondral repair once we figured out that there is a fracture involved or a subchondral insufficiency fracture present. Obviously, everybody has spoken about what to do with regards to previous treatment options. And lots of times we try to do that, And again, we see a lot of post-operative symptoms that we can't explain. So I think this is a great way of going about doing that. So I'm going to actually go through this. I picked a few cases just to go shortly. I know there is some time constraint, but just so you can kind of follow through the surgical technique that we have started doing. Everybody's got their own preference and comfort zone, but this is just something that we all agree on how to at least progress to get this done properly. So the first case I was going to cover is, the hallux limitus, and with that subchondral insufficiency fracture. And just to make a note, all these cases that I'm showing you have already had x-rays, but also MRI confirmation of the subchondral injury. So clinical presentation, you can kind of see the presentation, and sometimes even the clinical presentation of the patient does not seem to be excessively deformed, yet they are excruciatingly painful and life-altering nonetheless. So they present to you, and once you do your x-ray and you do your evaluation and you progress and decide that you do need to proceed with surgery. So this would be the initial glimpse into that joint intraoperatively. And you can see that the dorsal aspect of the first metatarsal kind of spurring out, and you can see the over bone growth and also the base of the proximal phalanx that corresponds to your x-ray showing the loss of joint space or narrowing of the joint space. So again, you can see further getting a little bit more exposure to the joint. You can kind of follow it. Here's the x-ray, and this is not something that I need to explain, but a lot of times there is an overlap, obviously, at the base of the proximal phalanx over the first metatarsal. But just looking at just this area, you can kind of start to appreciate something going on. Even if we didn't know what can be going on, at least this is giving us a glimpse that maybe we should look into this a little bit more in detail before jumping in and doing surgery, hence the MRI idea. Again, plantarflex the first joint, obviously the proximal phalanx, and then you start to expose more of the damage. You kind of see this. Now, obviously there is damage. This is before any colectomy or any other procedure yet, but you can kind of see the extent that can be causing further damage throughout. And then you can see how the part of it is peeling off the actual subchondral region. Then we try to actually start to measure the size of that. So this is the wire, the guide wire that I use and put into the joint. There is two lines of thought process that the wire needs to be perpendicular to the defect, and or if it needs to be longitudinal or long parallel to the long axis of the first metatarsal. This is definitely a case-by-case evaluation, because sometimes you actually have the first metatarsal that the articular surface or the pasa is a little bit deformed. So you really have to look at that radiographically, intraoperatively, to see where this wire needs to lie. So the other part that was very important to note, at least throughout the ones that I've done, that a lot of times when you put the wire in and you're looking at that, sometimes the defect could be just off center, but that doesn't mean the rest of the cartilage is not defective. So you really need to incorporate and evaluate and examine the whole head of the first metatarsal, not to miss anything. And the way I usually do that, if it's just off center, I pick enough, or I should say big enough implant to engulf not only capture the defect, but also make sure there is nothing left behind. What could be worse is doing this and then realizing that there is some other issue going on and you missed it through the case. So just to say that. So this is the sizer, and you kind of go through that. And this is also the reamer that you can kind of put in. So once you figure out the size, you use the same wire and you take the reamer and you try to do the countersink. And if you go through the countersink, you can kind of see how this kind of takes it through. You need to be careful, even though this is on power. Obviously, I don't need to explain the surgical technique of be aware not to forcefully do this. So you end up in the mid portion shaft of the first metatarsal, because that's important not to do, obviously, in this case. But then you try to get the initial part of the countersinking. Now, why is that important? And I'll show you in just a bit. This is about 5 millimeters, and you can kind of see this. This will be more clear in the future slides. but you can kind of see the little bit of a step that this is created. This encaptured the defect that we saw on that slide. Important is this 5 millimeters. So this is where we think that it needs to be in order to safely and properly seat that implant. So you can kind of do it this way. You can also use the back of your reamer as a measuring guide and slide it backwards on the same wire if you're worried about if you're measuring it correctly or if you're not holding it correctly. Then you try to actually fit this with a groove. And this is what makes the platform that receives the implant. And I'll show you in just a moment. This would be our subchondral, the S-core implant. And here's the dermal layer that you try to suture. Suture techniques are different. There are some recommended ways of doing that. You can actually take 3 separate sutures with 2 needle drives and have 3 separate sutures that are tied inside this platform or in this implant that sits against the bone, and it's very secure. I actually do like going through in a zigzag motion, which was also shown me in other ways by Dr. Zhang. However, I like that idea. And then I tie it so it becomes a 1-knot tying technique. But again, you have to develop your own preference in doing this, and whatever works in your hands need to be the way that it works. So now this is what it looks like with the implant underneath, the layer on the top, and then you try to put it into the system, into this whole defect. Now, the defect is, it's not really a defect, but it is in a way because you've created it, but you're trying to repair that damage. So there is the layer, there is the implant, S-core, there is our guide wire that we originally put in, and you basically start screwing that in that area to securely hold everything in place. This slide was put in just to show you in a very short few moments as we were doing this, it actually started kind of bleeding through. And it shows that bleeding that we really needed. Obviously, when we do the drillings, initially before this technique, we were hoping for some of this to surface. But as I think Dr. Bavarian said, this technique does help because it does come through and helps the revascularization part. Here's kind of a intraoperative view of that implant along with the dermal layer sitting in place. There is a little bit of, you can see the interface between the rest of the healthy cartilage. X-ray before and after, again, a DP view. Also, you can see a lateral. Some people, again, if you're more aggressive with your Valente type, you can do that. If you want to do more of an aggressive colectomy to clear that dorsal lip, you certainly can. At this case, I didn't need to do that. I'm going to go through these a little bit quicker. Case number 2, you can see this. The only reason I put this here, MRI definitely indicated subchondral insufficiency fracture underneath, but intraoperatively, when we looked at this, it didn't look really that bad. But when I use a freer, you could actually, almost like a saran wrap, push this off to a side and see it completely loose from underlying subchondral region. So again, we went through final result with the graft and the S-core implant in that area of the joint. And you can kind of see that. Here's the platform I wanted to make you see. You can see how the groove that we created, this is the original platform that we countersunk to about 5 millimeters. This sits on the underside of the implant and it protects it. So there's no way that you can proceed and progress this too fast or too deep. So this is a very easy process to do. And here is the final product there. This was interesting. There was a 41-year-old, it was otherwise healthy woman that came to me, and everywhere she went, they wanted to fuse her joint. The only other option was given to her was obviously joint implants, hemi versus total. At 41, even though I kind of like the arthrodesis plans for certain people, she didn't want to hear it at all. She was almost in tears. She wanted to do anything to try to save the joint. So here we go. X-rays before, you can see the joint disease in that area. This is what we saw when I opened it up. You can kind of see the defect, obviously, again, proven by the MRI. This was before the colectomy and cleaning of the joint. Here is the sizer going through. We created the countersink, the platform, And then we put that, I found it's easier to do it this way a little bit because you can actually handle the layer. And then when you suture it, then you can trim around it. Again, your preference, what you decide works for you the best. And then you feed it into that defect in that area. Here is what it looks like as you're putting in before it's flush. Here is where it is. And I like it. Obviously, we wanted it just a little bit under the surface to make that correct contact. Here is the x-ray again, lateral, DP. And the last case I wanted to go over was, obviously, this is not subject to only the first metatarsal. This was a lady with the second metatarsal. We did an MRI. The interesting thing was the MRI did not indicate a full subchondral fracture. I even had some back and forth discussions with the radiologist who would not commit to that idea. However, I sent this picture afterwards to the radiologist, and she was rather surprised that I actually encountered this. And so she corrected it, but my whole goal was not to try to correct the radiologist, but I just wanted to show you that what you see on the MRI may not be fully representative, but if you do see that fracture, trust me, you will see that in there. And here's the x-ray that you can see previously. You can actually see the defect on the x-ray beforehand even. And then here's the implant with this. Now the lesser metatarsals, I have not used the dermal layer. It just works very well. I feel like this defect in the great toe joint is a lot more need for that dermal layer. But again, that would be your preference. Thank you so much. I hope that helped. I will pass this towards Dr. Silverstein so he can carry this as well. Thank you.
Thanks, Shah. Can you hear me? Sounds okay?
Yes.
Okay. All right. All right. I just wanted to say thank you to everyone joining us on a summer evening like this. I know everyone's busy and has their own things going on, and summertime quickly gets away from us. I'm going to share 3 case studies of the S-core that I've experienced, and I'm glad I paired it with Shah's experience because mine's more on the radiology end and MRI findings. If we look at case study number 1 that I operated on, she actually is a control within her own self, because 6 months earlier I had done a hemiarthroplasty as well as a plantar flexing osteotomy of the first metatarsal, and she developed some post-op stiffness. And when it was time to do the right foot, I felt like this was the way to go. So she was a 57-year-old female presenting with great toe joint pain for greater than 2 years, worked on her feet, had shoe issues. The history of that discomfort was sharp in nature, began with end-of-day pain that progressed to all-day discomfort, and she was in retail, so she was on her feet all day. No history of trauma or injury. The only things that she had tried were taking her shoe off and taking Motrin. I believe we had tried other things as well. Her pain was a 7 out of 10 with an unremarkable past medical history. So on physical exam, we saw redness of the joint. We saw some swelling in that first MPJ. All the patients had adequate circulation at this age. Intact neurologic, and the pain with range of motion was at 40 degrees, mild crepitus, some guarding with that range of motion, and pain with palpation to the dorsal exostosis, as well as dorsal medial first metatarsal head pain. Now, why did I highlight that in yellow? It's becoming more and more important and obvious to me that we need to do, or I need to do, a more thorough examination to know exactly where the pain is. Is it medial dorsal or lateral dorsal? Because we're not just going in and drilling the head like we used to and putting a hemi implant in and cleaning up the joint. We want to know exactly. Oftentimes we go in intraoperatively and we encounter multiple erosions. So I would have classified this as a grade 1 hallux limitus. All of the patients that I did these cases on, I've ordered MRIs. I've been in practice 21 years. This was the first time I ever ordered an MRI for a hallux limitus. We were taught what to look for, and we know how to carry them through conservative therapy, and I took them to surgery. But now I'm starting to see that there is a bigger picture. These are the exact words off the radiologist that I'll read to you. Chondral irregularity and thinning, including in the metatarsal head and base of proximal phalanx, with likely superimposed small areas of high-grade partial and full thickness chondral loss of the metatarsal head. Mild reactive bony changes in the metatarsal head. Almost sounds like a stress injury that the radiologist is dictating for. I'll also put the caveat that I didn't discuss this with the radiologist going in. I just sent them with my script saying MRI right or left foot without contrast. And the diagnosis was first MPJ, degenerative joint changes. So preoperatively, when we look at our x-rays, we're going to hone in a little closer. Here was the right foot. You can see asymmetrical narrowing of that medial aspect. And when you're starting to figure this out, because you're not just going to be drilling, I suppose that when I went in intraoperatively that I would see a large erosion on that medial side. And on the lateral, we can see some dorsal boss with the skin also tenting up in a dorsal fashion. So treatment plan, they failed conservative therapy. We attempted and went through surgical planning for the S-core, as well as a chylectomy. Here you see post-operatively, and we'll zoom in closer. Again, this coincides with what Shah was talking about, where you have a 5 millimeter depth, and that's to help the 2.5 millimeters that account for the head of the S-core implant, plus about 3 millimeters for the dermal graft. And you can see that the joint space is a little bit increased. And we always like more joint space because that's going to help with the excursion of the proximal phalanx onto the metatarsal head. There's also some theories that the excursion helps lubricate the cartilage and bathe it in the synovial fluid. On the lateral, he was talking also a moment ago about going down to the long axis perpendicular to the shaft, or if you have to look at the cartilage, putting it in flush, because you want to have the implant seated firmly on the head of the metatarsal as you move it in, so there aren't any areas that are deeper than the other. We want it to be flush with the surface with that dermal graft. So here's pre and post-op, okay? And what I decided to do is, take a PowerPoint and draw all the areas of the shaded region in the joint so we can really see what we've done pre and post-operatively. And you can see that the joint space has been increased. Although we don't treat radiographs, okay, and we'll get to that more because all the patients did well with this. It is nice to see that they were increasing the joint space. Not all the joint spaces on my cases were increased, but they did have improvement in range of motion as well as the ability to bend their toe better and get back to their activities quicker. So here we see pre and post-op on the lateral, and we colored in the joint space, and a good result, and I was happy with that, and so was the patient. Case number 2, 56-year-old gentleman, definitely over 250 pounds, presented with left great toe joint pain times many years, worked on his feet with steel-toed boots. Pain progressed, again, only with weight bearing, but then got to the point where it was throbbing and aching with all activities. He attempted changes in shoes, different Red Wing type composite shoes, rest, cortisone injections, orthotic therapy with minimal relief. His pain was an 8 out of 10, which is interesting because his joints didn't really look that bad. But again, we're not treating x-rays. Medical history unremarkable. On physical exam, we see redness over that first joint, as well as severe first MPJ swelling, intact sensation. He had pain with range of motion on that first MPJ, and he did have about 50 degrees dorsiflexion with no crepitus. And he had more pain in the dorsolateral aspect of the metatarsal head. So again, it's always important. Your patient's out with general or under sedation to know exactly where that pain is preoperatively. So when you get in, you can make the decision on where to place this. And some patients, when you palpate lateral versus medial, will have the same amount of pain. Others will be definitely more tender in certain areas. Those are the areas that have the most damage and need to be addressed. So again, a grade 1 hallux limitus. This MRI definitely said bone marrow edema within the great toe, proximal phalanx, and distal first metatarsal, representing a stress reaction. Moderate degenerative changes of the first MPJ and hallux sesamoid articulation with joint space narrowing, partial thickness and full thickness defects, tiny cystic changes, subchondral edema, and subchondral edema in the sesamoid apparatus, as well as the osseous spurs that we typically find. This was his foot. Again, the joint looks pretty good. You see some subchondral sclerosis, really symmetrically narrowed joint. So again, it's important. I wouldn't have expected medial or lateral to know beforehand without a specific deviation in the cartilage defects. So it's important to know ahead of time, and I can't stress that enough. So the treatment plan after failed conservative therapy was to start with the S-core and do a chilectomy on the metatarsal head. So for him, when we got in, it was more pain on that dorsal lateral aspect. And we'll zone in a little bit closer. You can see that we left like 3 to 4 millimeters just lateral to the implant, which is important to avoid the cortex. So this implant stays firmly seated into the grooves that we've made and the channel. And again, 3 to 4 millimeters dorsal to the implant account for the dermal graft, which I agree is a necessity on that first metatarsal head. And here on the lateral, you can see this is more parallel to or perpendicular to the long axis of the first metatarsal. So here, when we compare pre-op and post-op, not much change. I mean, you actually do see some obscuring on the right-hand side, but when you color in basically the same amount of joint space, and he came out with great results, able to get back to activities pretty quickly. On the side view, a lot of superimposition and some soft tissue swelling because he's got a big foot. And we see that the joint is maintained pre and post-op. Third case, 59-year-old female presenting with left great toe pain greater than 6 months, aching with ambulation and worsened of late, pain 6 out of 10. She had tried courses of anti-inflammatories as well as orthotics with minimal improvement. On physical exam, she had absolutely no redness overlying that joint. She had minimal first MPJ swelling, but we know these cases from patient to patient can exhibit different clinical symptoms, and hers was pain that was pretty significant. Dorsiflexion, we had 45 degrees, no crepitus, some guarding felt with the range of motion. Her pain was on the dorsal lateral aspect of the head of the metatarsal, as well as the exostosis. So again, a grade 1 hallux limitus. Her MRI showed mild to moderate arthritis at the first MPJ with patchy marrow edema along the dorsal lateral aspect of the base of the proximal phalanx at the level of the dorsal osteophytic spur, and marked chondral thinning at the first MPJ. So preoperative radiography, not very exciting, some subchondral sclerosis, but not a lot of degeneration that we can see just from the plain films. And on lateral, again, you see the tenting of the skin as well as the dorsal spur. So treatment plan, again, failed conservative therapy. Surgery was planned to use the S-core on her first metatarsal, and her erosion was more lateral as well. And medially, the cartilage looked pretty intact. Whatever erosion I couldn't fill with the S-core, I did drill with a K-wire to stimulate bleeding and perhaps some fibrocartilage growth. On closer examination, again, we're keeping that 3 millimeters from the cortex and keeping about 3 to 4 millimeters for the dermal implant to go. When we compare pre-op and post-op, we can see that this joint space is maintained. And when we color it in, the space is about equal. And on lateral, we see a very similar type of findings. Post-op instructions for these types of cases, personally, we do weekly, then biweekly surgical site checks, guarded full weight bearing in a surgical shoe for the first 4 weeks, then slowly advance to a regular sneaker. This is going to change based on your preference. Start active range of motion exercises at 1 week out, and then passive range of motion exercises at 2 weeks. If the patient cannot perform the passive range of motion exercises because they're obese or they have back issues or can't reach their feet, be sure to have a family member or friend come to the post-op or pre-op appointment so they can observe how to do it. Post-op observations for these 3 patients. All the patients healed up without complications. All patients demonstrated significant improvement in the range of the motion at the first MPJ. Less scarring observed than traditional hemiarthroplasty. In the first case, she was her own control. More dissection to me means more scarring and more postoperative stiffness that can develop. And the more important it is for them to be doing these exercises postoperatively to help prevent that stiff joint from developing. So this is a lot less dissection to cause that. All patients demonstrated significant improvement in pain symptoms when compared to pre-op. And I'm not just talking about the range of motion, I'm also talking about palpating the head of the metatarsal, medial versus lateral, dorsal versus plantar. If we do follow-up MRIs, which I'm planning on doing, I think we're going to see a lot of resolution of that edema and subchondral insufficiency that Dr. Zhang was speaking of initially. Return to physical activities are quicker because we're not waiting for an osteotomy to heal and we're not waiting for a joint to fuse. Patients love that. And in this day and age where patients are worried about their career and their jobs and being off work too long, this fits right into that type of pattern. 0 joints destroyed with this procedure. It's a joint preserving type procedure that's very effective. When we talk about clinical pearls, in the first case, there was an asymmetrical narrowing of the joint. So I had planned on seeing a large erosion toward the collapsed side of that joint, which correlated with the point of maximum tenderness preoperatively. That is indeed what I found intraoperatively. I'm just going through my thoughts on these cases as I look back on them and how you have a change in how you think about these cases and how you plan for them. Cases 2 and 3, there was symmetrical narrowing of the first MPJ. So we needed to thoroughly examine the patient preoperatively. Again, that medial versus lateral head pain. And because as we know, when you get in surgically, there could be multiple erosions seen intraoperatively. And it's important, more important than ever, to know beforehand where the most pain is clinically. As I have about 45 seconds left, when we have that patient with a stress injury that comes in, hasn't been diagnosed, unrelated to hallux limitus, we know what we're expecting, a swollen metatarsal area. They've been on their feet but haven't had treatment. And because of that, they have a lot of pain. So when we take the x-ray and then see the stress injury, we put them in a cam boot. That cam boot, sometimes when they put it on, immediately gives them relief and they walk out without pain. I always tell my patients if they have pain after they put the boot on, they need to use crutches or a rollabout. So it's important to kind of think of the S-core as an internal cam boot where we're stabilizing that subchondral bone as well as helping them with their range of motion. And we're now going to be able to effectively and surgically manage the chondral defects and instability in the subchondral bone without destroying the joint. And without any further ado, we will turn it over to Dr. Dan Schulman.
Dr. Schulman, you're on mute.
I'm on.
There
No,
you
I got it. Everybody see my screen?
And we can see your beautiful face too.
Oh, yeah. Well, I didn't mean that. That was an accident. All right. Well, let's talk about, I think it was great lectures before mine for sure. I think we all understand the importance of the subchondral bone complex. But what if you have somebody with chronic inflammatory disease? I mean, it's not like the typical non-inflammatory arthritis that we're dealing with, and we're using S-core quite a bit. So I'm kind of going to present a case for you here. The
Dr. Schulman?
rationale, I kind of used a paper that I found recently. It was published in 2018, but it kind of talks about how chronic joint inflammation will cause the local osteoporosis, periarticular osteopenia that we always describe on x-rays. And, that directly itself will affect how the subchondral bone plate will be functioning. Inflammatory cytokines and TNF alpha and interleukins are all major suspects of this problem. So here's a patient, a 49-year-old female who was originally diagnosed with gout, now diagnosed with psoriatic arthritis because I sent her to a rheumatologist because it wasn't typical symptoms that she was having.
Dr.
Can everybody
Schulman,
hear me? I think somebody else has their microphone on.
we can't see your presentation.
Oh, you can't see it? I share the screen here.
Should we take a few questions while Daniel
Sure,
takes
yeah.
care of any issues? Oh, there it goes, Daniel.
Yeah, I don't know why it didn't work. I hit it twice. So, all right. Are we all back on the? Could you hear me now?
Yes.
Okay.
Yeah, good.
Let's just go here. That first slide is just.
You
an
might want to just
introductory.
go to the play mode so you're showing it.
Exactly. So.
Slideshow.
Slideshow, then
There we go.
play from start.
All right, there we go. So I'm kind of skip through this. That's, I'm just going to go to my case study here. Basically, this 49-year-old female had chronic inflammatory changes in her great toe joint, thought it was gout, sent her to a rheumatologist. They now diagnosed her as psoriatic arthritis. And, she didn't want to have a fusion of her great toe joint. I mean, these x-rays are absolutely miserable that I'll show you. And so I wanted to have another option for her. And this is what we wound up doing. So here are preoperative x-rays. You could clearly see the cystic changes in our first MPJ. Standard of care would probably be a fusion. But I felt like having introductory to this implant, I've already put just under 20, that I felt she would do great doing an S-core with, maybe a modified Valente. So what I do is I do just that. I do a modified Valente, put a 6 millimeter diameter S-core implant in the proximal phalanx, even though my intentions were going to put it in the head. You can see the cystic changes of the head made that unattainable. There's no way you can do that. And even opened up a cystic subchondral cyst with the dorsal cut of that first metatarsal head, which you could even see that trough exposed in that head, which wasn't really symptomatic when I moved the joint. She got freedom immediately after I did this procedure. And you could see this crater that I found in the proximal phalanx of the hallux. I mean, the only thing wasn't, I wouldn't be surprised if bats were flying out of there. It was like a huge hole. And, so I, instead of my plan of putting it into the head, I flipped it and put it into the phalanx, measured it there as shown by the technique by Dr. Silverstein and Dr. Ascari. No surprise there at all. And I packed it with bone putty. After it hardened, after I curetted it and then put the bone putty in, I now did the same technique as was shown earlier. You could see the allograft tissue, the dermal allograft here. And this is at 6 months post-op. She had a lapidus that I did, and the screws were becoming bothersome. So I asked her if I could open up her first MPJ to take a look, and she was all pumped and wanted to see what was going on as well. And you can see right here, completely covered over. It's probably, not hyaline cartilage, probably fiber cartilage, but you could see the defect is completely covered over. There's no hole anymore. And here's, what she looked like before. I don't know why this is covering this. Have you guys seen this bar over the pictures? Okay, we have a patient here.
No, it looks
good.
Here's a video. So this is at 6 months, hardware removal.
Bunionectomy, arthrodesis of the first metatarsal cuneiform joint, but she also had an S-core implant in her first metatarsal head due to a long-standing history of psoriatic arthritis. She's taking Otesla now, which is really kind of helping overall pain, swelling, and even function of her foot. This is only 5 days post-op of removal of the hardware lapidus. And let's just have you move your toe, bend it like before. There you go. Does it hurt at all?
No, not really, no.
Okay, well, some pain is normal, but I mean, now try to do it like a catcher squat, kind of bend it back like before. Does that hurt at all?
Well, I feel that,
Okay.
like at the joint,
Right.
it's not.
Because we did a video at your 18-week and you had way less pain, but you weren't having just an incision on your foot like how we do right now. So it looks, fantastic. I think you're gonna have a full recovery. I'm really anxious to see how we're gonna look when we get in shoes and back to your activity and fun and all that kind of stuff. So that's exciting stuff. Cool.
She actually did a freeze frame there. I didn't have her to do that, but you can see the post-operative success that we had with this. She was just elated. So you can see the 6 month post-op picture right before I took to take the hardware out to the bottom right, and compare that to that original picture up in here. It's just it's just incredible. It's an incredible change, and she's super happy. So I'm gonna turn it over to the the question and answer. And that's pretty much end of my section. So I just kind of want to show this amazing case.
Thank you, everybody. Those were very impressive presentations, and I really appreciate that. We have a number of questions that I'd like to let's see here. Okay. First one is the S-core screw has the strongest purchase. This is a comment by Josh Bigney. That's a response. I'm sorry. I'm not finding the questions. Can anybody else see the questions?
Tom, look in the answered part of the Q&A. That's where
Yes.
most of the questions are now.
Oh, there you go. Thank you so much. All right. What preoperative evaluation regarding gait analysis was tried to determine the etiology of the HR, and how was this pathology dealt with when comparing outcomes? I believe that was during Dr. Ascari's presentation.
Can you hear me?
Yes.
I actually tried to type the response in there, but I will say that we actually have done that. I mean, obviously, lots of instability of the first ray can cause jamming of the first metatarsal phalangeal joint out with the forefoot loading. So gait analysis certainly is a great tool to see that, but how to deal with it, orthotics postoperatively. But a lot of times that additional surgical interventions, such as the lapidus or the first metatarsal cuneiform fusion, can reduce that instability, giving that stable form to the first ray, kind of reducing that elevation of the first metatarsal head, which originally a lot of times causes that limitus issue from a structural imbalance. So to me, and everybody, please, respond as well. But to me, I think those additional procedures that you do find out may be necessary for kind of a longevity of this process, along with biomechanical control. I hope that answers the question.
Thank you, Dr. Ascari. Were there other questions? It looks like most of the questions that were asked in the chat have been responded to. Are there any other questions that you would like to have the experts answer?
I think there's one comment that I think that comes across as we're talking, and that is, we've started to realize that if you can try to separate the joint somehow and keep that bone-on-bone rubbing and reinforce the underside of the bone, that is the kind of holy grail, right? So Cartiva was failing because maybe the subchondral bone was not properly holding, or the implant was subsiding. And as Dr. Coughlin was saying, one of the things that was always worked fairly well was some form of a dermal matrix that you could wrap the head with. But as he mentioned, it's a pain in the ass. It's very hard to do, and you got to drill holes and put stuff through. And really, the one thing that the S-core offers is not only are you getting correction of the subchondral bone, but you have a fairly easy way of securing a dermal matrix directly to the cartilaginous surface. And even if you form a fibrocartilage, as long as you have a spacer there, you now have the ability to get rid of the subchondral pain and also cover the cartilage surface. So I think it has everything necessary to work really well, and it's fairly simple to do.
Well, Bob, I think I think that was a great point, that when we did the wrap, excuse me, when we wrapped the metatarsal head, we took off a bunch of cartilage that we didn't need to take off, but we had to do the whole baby there. We couldn't just do a spot area there, and that's where I think that the subchondral implant works if you can do a controlled placement. I want to just throw a question over to Richard, though, because that was a superb presentation also, as were all these. But Richard, a couple of questions have come in about how much thickness does the dermal graft have? And when I saw your radiographs, sometimes those implants were on the more plantar aspect, and it looked like it was in 4 or 5 millimeters. I don't think it was in that far. I think you ended up having a flush surface for your dermal implant. Is that true, or was it recessed?
It was not recessed. As you screw in the S-core, you get to a point where the implant itself is sutured down tight to the implant, and once it kind of rides around the rim of the drill hole, it kind of plumps up once it gets right below the surface, and you can stop. You can't keep going because this is basically like a hollow thimble that's over top bone. So the fenestrations in the implant itself helps the ingrowth of blood vessels and helps the structure of the subchondral bone. But it's basically, at times it did look like that. I think sometimes the graft does vary in thickness. And then when you hydrate it, there could be a millimeter there. But everything was flush because that's how I wanted to leave it. So flush with the surface.
Are you guys also finding that by suturing in and out, you're creating enough holes where the subchondral bleeding is also then coming through. Because one of the things we didn't talk about is that the S-core is got fenestrations in it to allow for subchondral bleeding. And I think that's really important.
There are holes in the dorsal surface, as well as there are like 8 different sizes or 9 different sizes, and each one has a different number of holes based on the size. There's a few different suture techniques and a couple of videos around to help surgeons that want to do this. But the fenestrations between the threads of the screw of the actual implant help with that ingrowth. So that's not covered by the dermal graft. So as soon as it's seated, you know that there's a communication between the bone that's inside the implant as with the subchondral bone surrounding the implant.
Really good.
I have another question that popped up here. Is there a decompression of the joint technique when using S-core, or is an osteotomy needed?
Yeah, I could address it. I mean,
Okay, go ahead. I'm sorry.
no, I think in all the, it's a very preoperative, going back to the preoperative evaluation, you're decompressing a first MPJ. I think it's like paramount to address like the elevation of the first metatarsal, whether the metatarsal is long, short, whatever, because that's gonna ultimately, no matter what implant you use, whether it's the S-core or anything, I mean, you have to have an alignment, because you can't possibly take your car in for new tires and not have an alignment of the car, with those new tires. So it's the same type of thing. So, and it does, a shortening procedure like a lapidus that also obviously treats the transverse plane is huge in this type of procedure, because you're accomplishing 2 things. And we see a lot of hybrid procedures, as you see. So that's kind of like my first go-to as a lapidus. So you're not addressing an osteotomy at the first metatarsal distally, which would interfere with the S-core implant.
Well, I think more importantly than that, you don't want to interfere with the blood supply with the distal osteotomy of the metatarsal. So,
Correct.
And you have to be careful, in going ahead. Colectomies more often than not fail in the long term is because you're not addressing the etiology. So with the S-core, you're stabilizing the microfractures that are present, but you still have to do all the alignment procedures, whether it be a repositional arthrodesis or lapidus procedure, or there's sometimes you have to deal with the proximal phalanx. If it's a long proximal phalanx, you may do a shortening dorsiflectory osteotomy with fixation. And understand, I mean, it's not one procedure that does all. I mean, when you're doing a chilectomy and then you're doing a repair, or in actuality, you're doing an internal repair of a metatarsal fracture with internal fixation. When you're stabilizing the subchondral bone, you're also doing a chilectomy, and then if you're doing if there's a instability and degenerative changes of the met cuneiform, you're doing an arthrodesis of the first met cuneiform. So you're actually not doing, it's not one procedure does all. You're doing 3 different, or 2, most of the time, 2 different procedures, sometimes 3. So you can't view this as well, I'm going to do this, I'm going to win. Well, we've been doing colectomies for years and we lose a lot. So you have to go ahead and you have to look at the total picture, and it's just not a one procedure issue.
So Carrie and our panelists, there's another question that popped up as far as just a failed Cartiva, and have more than one of you done a subchondral implant for a failed Cartiva, or have you not done that yet?
We have not done that yet. I mean, and part of the reason why we haven't done it is that early on too, I was also contacted to do it, and I just didn't feel good about it. So we haven't done very many we haven't done any in our practice. So
Cartiva.
The Cartiva, yes.
Yeah.
And but we have one of our elite surgeons who's had experience and it's had 100% failure rate with it. So he can really tell you what's going on with it more than anything else.
Yeah, I think as far as the Cartiva is concerned, the only thing that I've noticed is like with the S-core, you have a rim that's gone, but the center is there. With the Cartiva, that center portion's gone. So I think if you're gonna do an S-core, it would be nice to backfill the back end of the S-core with a bone graft and then put in the implant. The S-core is still gonna bite around the edge, but fill in behind the S-core so that you have basically something that's gonna then become a bone graft to hold the S-core in place and then have the cover put on. I'll tell you, my biggest issue with the Cartivas is the patients come in and they are like mentally exhausted. And so it's very hard to say, hey, listen, I'm going to try this other implant on you. I think it can work. And I know that Derek Deed was just saying he's done it. And I think it can work. I think that this can take the place of a Cartiva implant if someone's adamant about trying something different. I haven't had the chance to do it yet because the Cartiva failures are starting to disappear a bit.
Well, I think, Bob, that you're exactly right. Just like what Danny did when he used bone putty or whatever graft material you want after a failed Cartiva because there's nothing there. But if you're doing the fracture, when you drill that around, you're actually putting in a platform, the cage, the bones. You're actually compressing the bone fragments, if you will, and then it's bleeding through, and then you get bony ingrowth through from the normal bone from the outside.
Yeah.
So.
We have another question. Are there any reservations about using S-core when gout is identified?
Do you want me to take that question? I can take
Sure.
that question.
Go ahead.
Basically, here's the deal. Okay. You preoperatively manage a patient appropriately. You get them to the rheumatologist, you figure what their uric acid level is, make sure it's maintained. They're not hyperuricemic before surgery. And no, I would not have any reservations for that because I'd go there and clean it out, do my thing, and that'd be it. Much better than a fusion. Once you do the fusion, then they lose mobility and they're not happy all the time, whatever. Or there's other issues like the long-term postoperative course. This is a lot quicker postoperative course. So that being said, no, I would have no reservations doing it on somebody with gout as long as they're managed appropriately. And, I do a thorough job debulking the capsule and everything else along with it. So
I think
just like this patient I just did, it's inflammatory arthritis.
I think I'm going to jump in this as well. I agree with Dr. Schulman. I think it also depends on when you do your pre-op workup is how much of that joint is really left. If you have a lot of erosion with the gouty tophi in there and in the process of cleaning it out, you have no head of the metatarsal left. It really defeats the purpose of trying to do that. So I guess that the proper surgical planning and evaluation really goes into that. But if there is enough cartilage still left to protect and repair, I think it is justice to the patient not to try it.
Right.
So I think that would be the way I would go about it.
Yeah, I think 2 words: informed consent. That's it. Just let them know that there's a possibility of a fusion, and we're going to try our best to kind of re-salvage your joint. And the technology it works. We've seen it over and over. I didn't have to open up this joint to show you that it got covered over. We could see on arthroscopy over and over and over. But man, I was like, I think my jaw still hurts from it wide open after I saw it in the OR. It was really, it's so cool. So, I'm not going to say any more because I won't stop talking, but, I think it's just great technology.
Thank you, Dr. Schulman. There is another question that I'll take. How many years follow-up since first series of cases? It's over 2 years at this point. And I know a number of the surgeons on here have had close to that number of that amount of back or follow-up. Do anybody want to comment on their latest patients or their longest out patients? Furthest out?
Yeah, I'll take first response to this one. I think the longest that I have is I want to say about 1.5 years, I think. And I remember that when I started this, it's difficult. You tell patients certain things you want them to do and not to do postoperatively. With this particular patient, and it's kind of throughout all the patients that I've seen and done, it's difficult to tell them to sit and don't do a whole lot because they feel so good and comparatively to what they had before surgery that they're actually trying to do way too many high impact activities early on in their healing process. So that shows you how it's successful it actually is. And obviously more time is needed to really kind of go through that. But initial evaluation, at least by my patients, seems to be doing really great.
Thank you, Dr. Asghari. I have one last question, and it's what are your opinions in using this technique on AVN of the metatarsal heads?
Well, I think subchondral insufficiency and microfractures lead to AVN. So I think you need to have an MRI so you know the extent of what you're dealing with. But if you can get an implant to fit over the area, then I think you have a good shot at success. But I think if you truly have the avascular necrosis, I think you have to do what Dr. Baravarian said before. You've got to clean out that area and backfill the S-core with bone graft material. And I think you've got a shot because your other issue then is a fusion. You don't have anything else left to do.
You have to have a bony scaffolding present to put this implant into. And if it's not sufficient, you're going to fail.
Yeah, I think exactly as Dr. Coughlin is saying, especially on a second med head, you really have to think, what are your options, right? AVN of the second med head, you can do a med head resection, you can put in a metal implant, and we put in metal implants, but the metal is stronger than the bone, which is why usually the bone will fail before the metal does. And I think one of the things with the S-core is that you have a similarity in density to bone. And with the ingrowth, if you can get the subchondral, if you can get the S-core to sit properly, and then you're basically just putting a resurfacing in. And we've done some med heads where we do a med head resection and we take a tendon and make an anchovy out of it and stick it in there to act as a spacer. All you're doing is trying to avoid bone-on-bone rubbing. So the S-core should be just as good, if not better, because now you're securing the graft to the metatarsal head. So, I mean, this presentation made a ton of sense for everything you can do with this.